Acute cholecystitis is an inflammation of the gallbladder, usually caused by obstruction of the cystic duct, most commonly due to gallstones, also known as cholelithiasis. It is a common surgical emergency that final-year medical students should be familiar with in terms of pathophysiology, clinical presentation, diagnosis, and management. Etiology: gallstones, or calculus cholecystitis, account for 90% of cases. Gallstones obstruct the cystic duct, leading to inflammation. Acalculous cholecystitis occurs without gallstones, often in critically ill patients due to gallbladder stasis and ischemia. Other causes include tumors, parasites, or infections, though these are rare. Pathophysiology: obstruction of the cystic duct leads to increased gallbladder pressure and distension of the gallbladder. An inflammatory response occurs due to chemical irritation from bile salts, followed by bacterial superinfection, commonly from E. coli, Klebsiella, or Enterococcus. Potential complications include ischemia, necrosis, and perforation of the gallbladder. Clinical presentation: symptoms. Right upper quadrant pain is often sudden, severe, and constant. It may radiate to the right shoulder or back. Fever and chills indicate inflammation or infection. Nausea and vomiting are common in acute cholecystitis. Murphy's sign, which is pain and inspiratory arrest upon palpation of the right upper quadrant during a deep breath, is a key indicator. Signs: fever is usually low grade in most cases, but may be higher with infection. Tachycardia and hypotension can occur in severe cases. Jaundice occurs in around 15% of patients, indicating possible cholecystitis, which is a stone in the common bile duct. Now let's move on to the diagnosis. Blood tests are crucial. Leukocytosis indicates an increased white blood cell count, often due to infection or inflammation. Liver function tests, or LFTs, may show mild elevation in ALT, AST, ALP, and bilirubin levels. Serum amylase and lipase are also checked to rule out pancreatitis. Imaging plays a significant role too. Ultrasound, or USG, is the first-line imaging modality. It can reveal gallstones, gallbladder wall thickening greater than 3 millimeters, pericholecystic fluid, and a positive sonographic Murphy's sign. If the ultrasound is inconclusive, a HIDA scan is performed. Non-visualization of the gallbladder on a HIDA scan confirms obstruction. A CT scan is useful for detecting complications like perforation or abscess, but is not typically the first-line imaging choice. Next, we need to discuss complications. Gangrenous cholecystitis is a severe condition where the gallbladder tissue dies due to lack of blood flow, often necessitating urgent surgical intervention. Perforation of the gallbladder can lead to generalized peritonitis or a localized abscess. Empyema of the gallbladder refers to the collection of pus within the gallbladder. A cholecystoenteric fistula is an abnormal connection that forms between the gallbladder and the intestines. Lastly, gallstone ileus occurs when gallstones erode into the small intestine, causing a mechanical obstruction. Finally, let's cover management. Initial supportive care includes intravenous fluids to maintain hydration and correct electrolyte imbalances. Pain management is achieved with NSAIDs or opioids. Empiric broad-spectrum antibiotics are administered to cover gram-negative bacteria and anaerobes, such as piperacillin tazobactam, or a combination of ceftriaxone and metronidazole. Definitive treatment often involves cholecystectomy, the surgical removal of the gallbladder. Laparoscopic cholecystectomy is the treatment of choice in most cases and should ideally be performed within 72 hours of symptom onset. Open cholecystectomy is reserved for patients with severe inflammation, gangrene, or when laparoscopy is not feasible. For patients who are not good surgical candidates, a percutaneous cholecystostomy can be performed, where a catheter is placed to drain the gallbladder. 7. Differential diagnosis: peptic ulcer disease, pancreatitis, acute hepatitis, right-sided pneumonia, myocardial infarction, cholecystitis, and cholangitis. 8. Prognosis. Most patients recover completely after cholecystectomy. Delayed diagnosis or treatment increases the risk of complications such as gangrene, perforation, and sepsis, leading to higher mortality. 9. Prevention. Risk factor management. Avoiding obesity, rapid weight loss, and managing cholesterol levels can reduce gallstone formation. Early cholecystectomy for patients with symptomatic gallstones can prevent recurrence and complications of cholecystitis. 10. Key points for final year MBBs. Acute cholecystitis is a common surgical emergency. Most cases are secondary to gallstones. Diagnosis is primarily clinical, supported by ultrasound findings. Early intervention, especially cholecystectomy, prevents complications. Know how to manage critically ill patients and identify high-risk features such as gangrene.